All right, welcome to this explainer. Today, we are building a complete, highly detailed mental map of the posterior cerebral circulation. We're going to track the exact journey of blood from the neck all the way up into the brain. We are diving deep, really deep, into every single segment, branch, and critical variant. The goal here? To give you such an exhaustive, crystal clear understanding of this anatomy that you literally won't even need to open a textbook.
But hey, before we trace the standard vertebrobasilar system, we've got to establish a massive baseline exception, fetal circulation. This is a variant affecting a staggering 15 to 35% of patients. In these folks, the posterior cerebral artery on one or both sides is supplied primarily from the internal carotid artery via the posterior communicating artery, completely bypassing the typical vertebrobasilar route. It's a vital reminder right up front, Human anatomy is beautifully and famously flexible.
Okay, here's our game plan. 1. Vertebral artery basics. 2. VA segments and branches. 3. A deep dive into the pica. 4. The basilar artery network. And 5. Posterior cerebral artery segments. Let's get into it. Section 1. Vertebral artery basics. We start our journey right at the base. Normally, the vertebral artery, or VA, is the very first and largest branch of the subclavian artery. But in about 4% of cases, we see a variant where the left VA actually arises directly off the aortic arch. Functionally, we're talking about a pretty narrow pipeline here. It's roughly 3 millimeters in diameter, yet it's pumping a mean blood flow of 150 milliliters per minute. Think about that. It's like pushing half a soda can of blood every 60 seconds, just to supply the critical life-sustaining structures of your posterior fossa. Now, what's literally wild about this system is the sheer asymmetry. The left VA is dominant in 60% of cases. On the flip side, the right VA is hypoplastic, meaning it's underdeveloped in 10% of people, while the left is hypoplastic in 5%. We even see a tretic variance that just terminates straight into the pica, happening about 3% of the time on the left and 2% on the right. Moving right along to Section 2, VA segments and branches. So, the VA travels up in 4 very distinct segments. V1 is the prevertebral segment, heading from the subclavian to enter the transverse foramen, usually at C6. Then V2 ascends vertically through the transverse foramen, and it's importantly surrounded by sympathetic fibers from the stellate ganglion plus a venous plexus. Next, V3 exits the axis, curving backward immediately in a groove on the atlas. And finally, V4 pierces the dura, enters the subarachnoid space, and joins its partner at the lower pontine border to form the basilar artery. Now, along this crazy intricate path, it spawns some absolutely crucial branches. Take the anterior meningeal artery, arising at C2, for instance. This thing acts as a vital collateral life raft during vascular occlusions. You've also got the posterior meningeal, the medullary or bulbar arteries, and the posterior and anterior spinal arteries. Every single one of these plays a pivotal role in feeding the neuroaxis.
Which brings us to Section 3, the pica deep dive. This is the largest VA branch, the posterior inferior cerebellar artery.
Usually, the pica arises about 10 millimeters distal to the point where the VA becomes intradural. But, as we're definitely seeing a theme here in neuroanatomy, there are variants. In 5 to 8% of people, the pica has an extradural origin. And then there's the ACA-pica variant, where it just originates right off the basilar trunk where the ACA normally would.
To really master this artery, you literally cannot skip its 5 microsegments. First, the anterior medullary segment. Second, the lateral medullary segment. Third, the tonsillomedullary, which by the way contains the caudal loop. Fourth, the televela tonsillaire, carrying the cranial loop. And fifth, the terminal cortical segments.
Tracing these exact segments, M, LM, TM, TVT, and CS, you can see them wrapping intricately around the brainstem and cerebellum. It is a highly complex, tortuous path. Vascular surgeons have to navigate this with absolute microscopic precision. So here's the absolute game changer for clinical practice. During surgery, those first 3 segments, the anterior medullary, lateral medullary, and tonsillomedullary, must be preserved at all costs. Otherwise, you're looking at devastating brainstem strokes. However, the last 2 segments, the televela tonsillar and cortical, can usually be sacrificed with minimal neurological deficit. Before we wrap up the pica, we've got to note its 3 distinct functional branches. First is the choroidal artery, branching from that cranial loop to feed the choroid plexus of the 4th ventricle. Then you have the terminal branches, the tonsillohemispheric branch and the inferior vermian branch. Fun fact, that inferior inflection point on an angiogram, that's known as the copular point. Okay, section 4, the basilar artery network. At the junction of our two VAs, we hit the basilar trunk, the massive superhighway of the posterior fossa.
This trunk branches into a seriously dense, critical network. At its lower section, we find the AICA, the anterior-inferior cerebellar artery, which often loops right into the internal auditory canal and gives off the labyrinthine or internal auditory artery. Moving up, we hit the pontine branches supplying the pons, and finally, just below its termination, the superior cerebellar artery, or SCA, complete with its superior vermian branch. And finally, section 5, posterior cerebral artery segments. We have made it to the very top of our vascular journey. Just like we promised, no skipping the details here. You won't need a textbook after this. The PCA is split into 3 main segments named for their surrounding cisterns. P1, the peduncular segment, gives off mesencephalic and interpeduncular thalamoperforators, plus the medial posterior choroidal. P2, the ambient segment, spawns the lateral posterior choroidal, thalmogeniculate thalamoperforators, and several temporal, parieto-occipital, and calcarine arteries. And P3, the quadrigeminal segment, gives us the quadrigeminal, geniculate, and posterior paracallosal or splenial arteries. Mastering this dense roadmap tells you exactly what tissue is at risk during a stroke. Now, while we're on that P1 segment, we absolutely have to talk about the artery of Pertron. It's rare, sure, but it is a highly significant anatomical variant. Instead of your typical bilateral perforators, a single solitary arterial trunk arises from the proximal segment of just one PCA. But, and here's the kicker, it supplies the paramedian thalami and rostral midbrain on both sides. A single occlusion here causes a catastrophic bilateral stroke. Pulling the whole shebang together, we can visualize the complete interlocking web we've just built. Trace it from the vertebral arteries at the bottom, follow those tortuous loops of the pica, travel up the basilar trunk past the AICA, SCA, and fan out all the way through the PCA into the deep calcarine branches. Every twist and turn, beautifully interconnected. So I want to leave you with this final thought. Given the sheer density of critical variations we just covered, knowing that up to 35% of patients have fetal circulation or that 5 to 8% have a variant pica origin, how might these anatomical exceptions completely change the outcome of an otherwise routine vascular intervention? Anatomical rote memorization isn't just some academic exercise. Knowing exactly what's on this map and what shouldn't be is quite literally the key to preserving a patient's life. Keep exploring, keep questioning what you see, and I'll catch you in the next explainer.